Very good. Well, kia ora koutou. Good evening to you all from here, from Wellington here in New Zealand. If we could just jump into the next slide, please. I'll kick off with that one. So just by way of introduction, in terms of the Mental Health and Wellbeing Commission, or Te Herenga Mahara, where Laura and myself are sitting. Richard sits elsewhere, Te Pou, he's one of our partners. We are a independent sort of Crown or government agency that monitors. We have a role to assess and report on mental health and addiction service and system performance. So we've been established about 5 years ago. We've been in the system since 2021, and we're a small commission, but we do have a very important role in terms of sort of using data and evidence to monitor performance and also make recommendations for improvement. So we look across whole public funded mental health and addiction system in New Zealand to identify what's working and what can be improved for people that are using services in the system. So in terms of the 2026 report, we helped sort of host and coordinate the information and the data from New Zealand North Te Pou and also Health New Zealand, the main kind of service commissioning arm in New Zealand, and the Ministry of Health. So we've got kind of a coordination role here in New Zealand. So one of the ways we've done monitoring of the system, of the mental health and addiction system, is through system performance. So it's the second year that we've done that, and it's kind of like a national report card in terms of how well people are experiencing and travelling through the system. I'm talking quite high level here, so I just want to talk through some of the things that we're interested in terms of what a good mental health and addiction system looks like. So just some of the things that we report on are things like the extent to which there is lived and living experience in the system. So this peer support sort of workforce, effective services for people with high needs. So we've got particular population groups here in New Zealand that we're monitoring in terms of their level of access, the experience they're getting, and also the outcomes that they're the results that, the outcomes that are being achieved as a result of interacting with these services. Another area for us that we're interested in is in primary prevention and early intervention, and the extent to which those parts of the system are being funded and how the mental health system is supporting that. Equity is big for us, especially for young people. We've got a big focus on the extent to which services young people are accessing services, mental health services. We've also got a focus on human rights-based practices, so coercive practices, and workforce. So there's a whole bunch of measures and data under each of those 6 key focus areas. And just as an example, this year, a couple of areas that we, after looking at the data, that we made recommendations for improvement on were the coercive practices, or we found that coercive practices in New Zealand, especially seclusion, were too high and inequitable, especially across some of our Māori and Pacific populations here in New Zealand. So we did call for faster progress to end seclusion. That's part of our role here in New Zealand as well. We advocate very strongly. And the other area was unmet need for young people. So that's kind of how we use our monitoring and reporting. We use it to create change and to make recommendations. And the awesome thing about benchmarking is we can understand system performance in New Zealand in the context of other systems and other jurisdictions. Because what we don't know is, how system performance is being measured across other jurisdictions, even in Australia, and how we sort of compare. There are some metrics that Laura's going to talk to in terms of comparison, but it really helps us understand how we're doing on some of these critical indicators. So in this particular presentation, we're going to dive into 2 particular focus areas for the Commission and for the wider system here in New Zealand, and that's seclusion and child and youth services. And we're going to talk a little bit about how this piece of work and the internet and the benchmarking work has provided, that much needed context for how people are faring in terms of services here in New Zealand. So that's just my little intro, and I'll hand it over to Laura just to take us through the next slide.
Kia ora, hello from New Zealand and Wellington also. It's lovely to be here. It's coming up 8 p.m. here, so it's the end of our busy day and the start of your busy day. So it's my pleasure to be here. I am going to talk a little bit about our system performance monitoring approach, and then, as Ella said, I'm going to apply that to two areas of really strong interest to us in Aotearoa New Zealand. Te Here Mahara Mental Health and Wellbeing Commission, we're just beginning our journey into system performance monitoring. We've done a lot historically of service monitoring, looking across the mental health and addiction services, both primary and community specialist and inpatient specialist. But as we all know, services operate in the context of a wider environment. And that's the legislation, the policy, investment, infrastructure, workforce, that all influences how services operate, who they see. So we're really interested to understand both services, but also that wider context of system, because as a national independent Crown entity, a national advisor, we have an opportunity to influence those policy and structural decisions. So we want to be considering that system level as well as service improvements and service experience. So we've just completed our second annual monitoring report, and that looked at 20 quantitative measures that spanned expenditure, workforce, system leadership, lived experience leadership, as Ella said, human rights and equity. And one key metric that's really, really important to us and the lived experience communities that we serve is solitary confinement, also called seclusion. So as you can see from this chart, seclusion in New Zealand has been trending down over the last 20 years. It's been driven by investment in several nationwide quality improvement programs. That's good news. It was much too high. It remains too high. If you jump to the next slide for me, please. Thank you. So like I said, seclusion has been trending down, but international benchmarking shows us what's possible. It shows us what's possible and drives us to advocate for better. When we look at New Zealand stacked up against comparable countries, our rates of seclusion, even after the massive fall that they've taken over time, are much, much higher than many of these other countries that we compare to. So international benchmarking and the information we gathered from that, it informed our recent recommendation to the government to plan towards the elimination of seclusion. We're really delighted that that recommendation has been picked up in an implementation plan for the new mental health and wellbeing strategy that New Zealand has just launched. Advocacy and action with the information that we gather through something like the NHS benchmarking enables us to stand firmly on the ground. Someone's saying they can't see the slides.
Yeah, thanks, Steve. Is everyone else able to see the slides? It looks like others can. Apologies. If you can't, sometimes leaving and then coming back can help. It looks like the majority can, so apologies if you're struggling. We will send the slides out after as well. Looks like the majority are fine.
Oh, that's good to know. Thank you. Great, you can jump to the next slide. So I wanted to talk a little bit about another area that's really important to Te Herenga Mahara, to the Commission and to New Zealand generally, and that's mental health of children and young people, and wider well-being of children and young people in New Zealand. What we know and we've seen also happen in many jurisdictions internationally is a context of rising psychological distress among young people. We see it through some of the survey data we gather in schools and in our national health surveys, that the prevalence of distress has risen markedly. What we've seen alongside that is that access to specialist mental health services has remained flat or has decreased slightly over time. So you can see on this chart, this is our access rates by age group per 100,000, showing that we have seen a particularly decreasing trend among the 19 to 24 age group and the 12 to 18 year age group. So our work looking at changes in access and looking at declined referrals from into specialist services suggests an unmet need, and that potentially an increasing unmet need. But when we look at the international benchmarking data, if you jump over a slide, my last slide, I promise, we're actually we're at the higher end of access per population. So it's just, it raises more questions than it answers, I think, but it is really helpful to look at those international contexts and those international models and see how different models respond to changes in demand, and how we might see our system. So international benchmarking shows that we have a reasonably high access rate. I think that someone said before that the devil's in the detail, and that's absolutely true, because it's quite important to understand what's counted in each of these specialist services, these community services. But nonetheless, it raises some questions for us, and it's really helpful to look at how different systems support young people and their mental health journeys. I hand over to Richard, who's going to talk from a different perspective again.
Kia ora, Laura. Big shout out to Joe and Emma. Thanks for pulling this together, and it was great to hang out with you in Ottawa and meet you there. And a big shout out to Stephen. I'm not sure if you're still there, trying to find your screen, see the slides, but lovely to see you again, Stephen. I'm just going to quickly go through the mechanics of how we actually understand the data in New Zealand. And I have to do another shout out to Hilary Sharp, who knows far more about this than I do, but Hilary, I hope I do you proud. So in New Zealand, for our service level data, we have a system called PRIMED. So that's the Program Integrated Mental Health Data, and it collects data from all our mental health and addiction services, specialists and NGOs. We look at things like diagnosis, referrals, social indicators. So the social indicators are housing, employment, GP or health registration with our PHOs. We use a unique identifier for people using services. We look at the activity data, who, what, where, why, the legal status data, and the unique thing about PRIME that it has outcomes data. So way back when, we set ourselves a challenge to sort of, can we start understanding, and I think Joe mentioned this, are people actually better off from touching our services, the investment we put in our services? So we used, so we got outcome measurement built in there. If we go to the next slide, we can have a look at the the outcomes. Wow, that's not such a good slide from my point of view, but I'll have a crack at looking at it. So we got the NAR primed. It sits right up top. We've got the outcome measures. So we have an addiction measure. So it's called ADOM, alcohol drug outcome measure. That was designed in New Zealand for New Zealand use. And the reason we designed some of the measures is because we have a sort of a bicultural approach when working with Māori in New Zealand, who are Indigenous people in New Zealand. We have a treaty agreement that sets the foundation for us as a health services, and Te Tiriti o Waitangi. And then we have the HONOS family of measures. So we have HONOS, HONOS Secure for use in forensic services, HONOS 65 plus for older people, HONOS LD for learning disabilities, HONOSCA for child and young people, and HONOS-C, which is our most recent tool added to the collection now. HONOS is HONOS for infants. And then from that, we have, we can go up the side there, we have our KPI, national KPI program, and we have adult, child and youth and forensic streams. Now that's all fed from our national collection. So in some ways, we're quite lucky that we have compared to other parts of the health system, where we have a unique collection for mental health and addictions. And that's one of the ways that we're able to contribute. You would have seen at the start of the slides, we've consistently been a contributor to the international benchmarking program, because it is a little bit easier for us now. We've been going since 2008, so it's 18 years. And it's a good program. It doesn't do everything that we want it to do. It doesn't collect workforce data. It doesn't collect financials. It doesn't collect quite a lot of things, but it does have a place for us. If we jump to the next slide. So from the prime data, we are able to drive our own national KPI benchmarking program. Nowhere as sophisticated as the NHS benchmarking, but we do have a good crack at trying to do the best we can. And so this is really just a screenshot. You would have heard Laura talking around seclusion. It's a really important part of what we're trying to do as far as elimination. So you will, in seclusion, we will people of Māori descent are secluded, but far too much, far higher than the general population. And it's a way that we can, these dashboards are available to the workforce or anybody working vaguely in the mental health and addiction sector. And they're interactive dashboards, so we update them monthly. It does take 3 months for the quality of the data, get that quality piece in place, but they are available to the workforce. Now, some of the dashboards that we look at, so we do look at seclusion, we look at wait times, we look at continuity of care. That's trying to understand some of that community space between inpatient and community. 7-day follow-up, 28-day readmission. And one of the from what I can gather from being part of the international benchmarking, we actually have an indicator on whānau engagement or family engagement. We're really interested to understand the pathway or understanding families' connectedness with their loved ones' pathway through the system. How do is that making a difference? What does that look like? And we're pretty sure it does. And we're pretty sure that we want to encourage services to be involved in whānau or family as much as possible. It's not always possible, but it is something that we're really interested in. We're hearing from our service user leadership that this is an important piece. And so, yeah, a big call out. If there are other countries out there doing something, we'd love to hear from you about that. We kind of promote the KPI program as also been able to give a voice to those that can't, are often silent in treatment pathways. What is the story that's been told? We've, been given unfettered privilege to look at this data on behalf of people using services, and how do we tell those stories? How do we design out inequity using data? And those, it's a really important part of our KPI program. And I just finally, one of the things that we really are missing, and I think Laura, you touched on, is around that prevalence data. So we can see in New Zealand, we have a health survey, we survey people, and we can see that the psychological distress is rising for young people. But what we can't say is why. What is happening there? What are the causes for this? And without really good prevalence data, which we don't have, is over 20, or coming up 25 years since we last did a survey on prevalence. And with the help of the Commission, we've sort of been, through their advocacy, we've kind of lobbied the government last year to, we've got to do better. We've got to invest in understanding prevalence. We're investing in buildings, bricks and mortar, and certain treatments and tools, but do we really know if that's what's needed? So big shout out to the Commission supporting that. So from that, we do have a commitment to do a youth study, child and youth study. I think the design of that's happening as we speak. And part of the benchmarking this network, we did hook in with the Northern Irish, who recently have done a prevalence study, and sort of some learning around how they've done that. And I think that's enough for me. I will hand it back to you, Emma, Jo.
That's brilliant, super interesting. Thank you. It's really great to see sort of how you sort of translated the data and used that sort of international perspective to really hone in on some specific areas for you to kind of dig into in a little bit more detail and think through sort of how you can use a kind of knowledge and experience to improve those services. We haven't had any questions. If people do have any questions, please do bob them in the chat or put your hand up and we can bring you in. We've had one comment around Triangle of Care is a major programme in terms of family unpaid carer involvement in mental health services. So looks like there is pockets of this work happening. And I think from an NHS benchmarking perspective as well, we are kind of exploring how we can use more sort of narrative and qualitative data in terms of understanding different viewpoints as well from a kind of patient or even a family and care or staff perspective as well, and being able to triangulate all of that with the sort of more standard quantitative data gives a really rich picture then in terms of what's happening. Did we have
Can I just come in, Emma?
Yeah, go on, Jo.
The first thing I wanted to say is, Richard, I apologise for your slides because it didn't look like that when you sent me it, but when I've copied it over, it's applied our theme, which is why it was that horrible green colour. So when I share the slides, it will be as Richard intended. But the other thing I just wanted to mention is it was interesting at the start, Ella, that you kind of touched on that kind of case for change, because that's kind of exactly what Stephen McLeod from the Scottish Government was talking about as well. It's that, and it links back to what Emma said at the start, as what one of like the most powerful things about benchmarking is being able to use it to almost hold up a mirror and challenge or support kind of policy decisions based on the data that that is made available by comparing yourselves internationally. And I thought it was interesting as well, Laura, when you kind of mentioned that it raises more questions than gives answers, because that is kind of the ongoing comment, I suppose, that we get as part of benchmarking, and we are really open about that. It's not always something that answers questions. In fact, I would say it rarely is, but it makes you ask the right ones, and that's what is part of that kind of process of holding up the mirror, if you like, to drive you in the right direction. And then just finally, your point about prevalence, I think, is super interesting because, again, Stephen mentioned that yesterday. It's one of the comments we've had consistently over kind of the life of the international benchmarking work. But as you kind of rightly point out, that data just doesn't flow in quite the right way. So there's definitely work to be done kind of in each jurisdiction, but maybe there's something we can do in the interim to kind of help better understand that. I do know that as part of the collection, we ask the question about people who are people's kind of housing situations and where people are being signposted into services from, but the completion of that is always really poor because, again, as you've rightly pointed out, the data just is not available in a way that is comparable. So they were my thoughts anyway.